expectations for what is taking place here in your program with the food markets and pretty soon, I guess, some community gardening. I like to grow lots of things in the garden, and I'm also like an amateur mycologist. I'm really into mushrooms. So um, for all of their benefits. And I'm also a therapist. So I have a practice called Pure Potential Unlimited. And in my practice, I actually support women in the postpartum period, as well as young adults and couples. And one of the fun things that I am currently getting into is adding ketamine assisted psychotherapy to my practice. So, fun fact about me, and I'm going to turn it back over to Rochelle, and we're going to go through our agenda for the day.
Okay. So what are we going to do together today? So we're going to start with the welcome and introduction. So again, after I finish walking us through the agenda, we will go around to learn who's in the room. We have a really fun icebreaker where we'll use our beach ball because we like to make things engaging. Then we're going to define equity and health equity. It's really important that we all have the same definition as we're going through the discussions for today. We'll have a infant health equity discussion. We're going to explore the social and structural determinants of health. As you know, that is a key component of the Catalyst for Infant Health Equity program. We have some examples of the social determinants of health. The social and structural determinants of health impacts on health equity, infant health equity. Then we'll look at some strategies to improve infant health equity. There'll be a small group activity, which should be a little bit fun. And then also we'll have a small group activity discussion so that we can all learn from one another. And then we'll wrap it up with another fun song. So let's go around and do some introductions. Oh no, we're going to do the icebreaker for the introductions,
That's
right?
part of the
Okay, cool. So Melody, could you please introduce the icebreaker?
Yes. Okay. So we're gonna stand up because we got to pass this ball around if everyone is able. Um, and sorry for the folks that are on the live stream. We can't, have you engage in this, but this is a way to get the day going for us. And so there's a beach ball that we're going to toss around. And once you get the beach ball, and just toss lightly, yes, we want you to share your name. We want you to give the reason for your involvement or engagement with the New York Catalyst for Infant Health Equity Project. And then once you get the ball, like wherever your right thumb lands, you're going to answer a question. You're going to read and answer a question related to where your right thumb lands. And so let me get out of presentation mode so you can see the questions. And everybody see that pretty well? All right, so we'll demonstrate.
Hi, everyone. My name is Dr. Rochelle Logan. I just said all of those things. My thumb landed on orange, and I can't see what that says.
Why are some community members healthier than others?
Personally, I think some community members are healthier than others because of access. If you live in a certain location, you may have access to fresher foods, you may have access to better care, and I think that's why some are healthier than others.
Hi, I'm Melody Watson, and I'm project officer working with your grant and the fabulous Angela Ramos over there. So my thumb landed on red, and so what does it mean to be health literate? So I think it basically means you understand concepts of health, like maybe when your doctor is telling you about a diagnosis that you have, or something going on in your body, you get to understand what that means, and that means possibly you're health literate. Right, so I'm going to toss it.
Hello, everyone. My name is Elsie Jenkins, and I am here as an independent contractor in health and wellness. I've owned and operated a produce store. I still sell mushrooms, but I'm also immersed in health and wellness with all communities. Let's see, orange, and I took my glasses off.
I'll read one for you. Why are some community members healthier than others?
You guys talked about access, but it's also the culture. Um, and I can say when I'm in Montclair, you want to exercise because everybody around you is jogging, walking. There's all these fitness centers, and part of the culture is to work out. In other spaces, that's not the thing. So that kind of pushes you to be a little healthier.
Right.
I could throw it in.
You can throw it anywhere. Yeah.
Okay. My name is Hargauri. I also go by Harry, like Harry Potter. And I work with Angela Ramos and my team over here, Mecca and Steven and two others, for the Infant Health Equity Catalyst Grant. And my thumb liner in yellow.
Okay.
So,
So you could pick either one because we're gonna have to repeat some of these anyway. So
according to me, I feel being healthy means you are aware of your lifestyle choices. You being mentally and physically healthy, like taking care of your mental well-being, and emotional well-being, and just an overall like holistic approach to health and life.
beautiful.
I'm just going through it diagonally.
Good morning, everyone. My name is Sandy Estrada, and I work with Horizon NJ Health. I'm here filling in for my manager, Iris Cooney. I believe a lot of people here know her. And I oversee our GED program that we have called Education Works. And my thumb landed on green, so I think this culture influence. Culture influences health a lot. Like a good portion of your health is based on your culture, how you're raised, what foods you eat, what is part of your traditions, and so forth. So, they're over to my colleague.
Hi, I'm Karen Sneed. I'm also with Horizon NJ Health. I am on the same team as Sandy and Iris. However, I'm more involved in the community events. I'm the promotional coordinator. So we do a lot with maternal events. So I'm the one going to the stores, getting the diapers, getting things that we provide. We call it a baby and kid pantry. And so me and my counterpart Elvin are like, we're in it. We get it. We go to the stores. We get what community partners request us for to help out. Anyone right? What type of resources make a neighborhood healthy? I'm not gonna lie, I suck at these. I know for me, probably. I mean, I grew up in Trenton. Where I grew up, we didn't have a lot of. So with riding the bike, but if I'm thinking, seeing how my daughter is now, like there's a lot more walking and stuff for her. So research making neighborhood health, things to get you outside. That if there's more outdoor things, kids are more inclined to be outdoors than on the electronics.
My name is Elise Joy. I am a founder and executive director of an organization based in South Orange called Girls Helping Girls, period. We provide millions of menstrual products all across the state to more than 100 different agencies. And we also teach workshops that teach at all levels, but mostly fifth graders, just the very basics of manage your periods safely. We don't necessarily learn in other ways. My phone's on orange or green, so I will find one I like.
So these are your orange and green options.
I'm actually gonna repeat what you just said. How does neighborhood environment influence the health of families? My two daughters were co-founders with me. One of my daughters has gone on. She was 14 when we founded the organization. She now has gone through school, has a degree in environmental science, and works for an organization, Casey Trees in DC, which you all may know. And she works on their education team. And one of the things they're doing is trying to reforest in the neighborhoods where families are, because they are significantly hotter in the inner city. And it really leads to a lot of issues for a range of issues, asthma, all kinds of stuff, as you can imagine. There are they recently did a research project that showed that it is 10 degrees hotter
Mm-hmm.
in certain parts of DC than in other parts of DC, and it absolutely tracks to the resources that are available in those communities. And so that is the way that. Yes. Ready? Okay. My name is Zenaida Steinhauer, and I'm a registered nurse. I work with Helen here, who's the founder of Dow Consulting. So I am an independent consultant. I retired from the Department of Health 5 years ago. I can't believe that it's been that long, but I still feel very connected to the Department of Health. I used to work for the State Birth Defects Registry as a compliance officer. I do a lot of volunteer work, one of which is with the Filipino American Cancer Care, which provides financial assistance to individuals with cancer. And a lot of the assistance come from the Philippines because it's such a poor country. Mm-hmm. So what else do I do? I do help, of course, more community health with the Infant Health Catalyst Grant, and we have been involved in the time and evaluation of the program. So my two thumbs are actually on this orange, and there's two questions there.
Yeah, pick one, whichever you like.
I'll pick one that hasn't been answered yet. How does housing impact health? I think that's a very important question because people who don't have a place to live in or a permanent home actually may not have access to many of the resources, in the community. They could be homeless people who may not have anywhere to live. They probably would be, I guess, picking on certain things that, like, is it important for me to pay the rent or to have food, in the house? So it's a lot of challenging choices for people who don't have their own homes. And it does affect health in a very big way.
Not too far. Good morning. My name is Helen Bao, and I'm the founder of Dow Consulting Services, and we are a healthcare consulting practice that work with many different community-based organizations specializing in POCs. And we have been involved with Newark Community Health Center, the Catalyst Grant, for a couple of years now, taking the charges. So just like that melody, I do grow vegetables in my little garden. I have to share with the deers. Many times this year that was cabbage, and I do forest, which is mushroom.
Oh, nice. Just these mushrooms.
Meet a lot of people that love to eat food. Especially right now, chicken in the woods. I find a lot of
Like tacos, yeah.
Try to, I have tried them pretty much all of them. That have a couple of my favorite ones. So my mom is on green. So how does neighborhood environment influence the health of families? I think this is a very important question because as we work in the community with different families, we also learn that the composition and the dynamics of families are different. There's a lot of influence from the environmental sector and how they make choices, healthy choices about themselves and the family. Culturally, we heard about that culture, not just the race and ethnicity culture, but also the neighborhoods where they live and the groups that they socialize with. They have sort of influence. So definitely, a neighborhood environment influence how families make decisions about the food. An example would be in what neighborhood they in. Do they have readily access to healthy food and fresh vegetables and fruits, they can have access to food. We all do, but is it nutritious? Is it healthy for us and our families? So definitely has that significant impact on how they make healthy choices.
Beautiful. Thank you.
Good morning, everyone. My name is Paula Green. I'm a volunteer with Girls Helping Girls, period. My background is critical care nursing, and I managed a pulmonary practice for 25 years at Kessler Institute for Rehabilitation. I volunteer at a lot of different organizations, but my focus is Girls Helping Girls. I do community outreach with partners, and so we started part of the mission team that met with the legislators 7 years ago in New Jersey to bring menstrual products back to the school system. So for all of you who don't know, as of September 1st this year, those products are supposed to be there. Yes. That they should be in the bathroom, but if they're not there, that there's resources to get them. How does parental education influence the health of infants? It's vital. Children don't come with a manual, and if parents, especially our new parents, are not properly educated by those who are managing their health, they don't know how to manage that child. And the more information we can give to them, the better off they are to give that child the health and the services that they need. And that's going to be nutritional, physical, emotional, psychological, and social.
Okay. Hi guys. My name is Stephen Leone. My manager is Angela Ramos. I work with Hargary. I work with Mecca and Vivian and all my colleagues across 6 states. Actually, I work as a case manager slash outreach worker. And during these years, I got the opportunity to know all the needs in the community. Many of these moms that come to our facilities, they need Medicaid, they need resources such information about food banks. I refer to different organizations, and some of them need legal assistance. So I refer them to the Department of Justice or Catholic Charities. So basically, as a program, we not just help them out with resources here in our organization, but we also refer them out to other organizations in the community. Most money. I'm in green, I guess. Okay. So I'm going to choose the last question, which is, how does green space contribute to a healthy pregnancy? Well, green, it's so broad. So I'm going to try to see if I can get a right stab at that question. So basically, well, moms have to eat green, lettuce, cucumbers, green soup. Eats less greasy food. Like, you don't want them to start eating McDonald's every single day because they have to watch their blood pressure, cholesterol levels. So one of the things that we also have in our health clinics is that we have nutritionists. And we were trying to do is that more to many of these moms to give them a diet. Normally they need to know how to eat, right? Because it's not about the health of the mom; it's about also the health of the baby. So it's one of the things that we're trying to do here through our farmers markets and also with our nutritionists and providers that we have here at NCH.
Awesome. Thank you.
You're welcome. Yes.
Hello, everyone. My name is Maya Tillotman. I work for Spence Chapin. We are an adoption agency. We also offer a lot of resources to birth parents, the adoptive parents, as well as we have a special needs program. So we have a lot of resources for children that are born with any kind of special needs. My office is in Newark. I'm right here, but our headquarters are based in Manhattan. I'm on blue.
So yeah, what does poor health mean, and how does parental education influence the health of infants? So you can pick either or pick whatever one, honestly. Okay.
How does parental education influence the health of infants? I feel like if the parents aren't educated on what's good for them, they're not able to provide the proper knowledge to their kids. It will also result in them making poor choices in what they're feeding their kids, what kind of products they're using for the kids, not only what they're eating, but also what they're using on their bodies, what they're playing with. So I think it's very important to educate the parents properly so they can pass that along to their children.
All right. Thank you.
Okay, first of all, I'll figure out the color out. My name is Iris Wells. I am a coordinator for the Bridges program with Goodwill Industries of New Jersey. We are an organization that's New York and Northern New Jersey. Our corporate office is in New York, Manhattan. Um, I'm the coordinator for the Bridges program, but I advocate for all of our programs and services. So overall, Goodwill serves individuals from 14 up to adult. Um, and it's supportive services for their needs, helping them move into their next level, whether it be going back to school for their education or getting a job or moving into a trade of the career and helping them on that path to get to that point. Um, my color,
So where did your right thumb land?
orange.
Orange. So you have two questions, or actually, if you want to pick another one, it's up to you. But in orange, we have why are some community members healthier than others, and how does neighborhood environment influence the health of families? So pick either one of those.
Why the, okay, why can't I see?
Which one? How does environment influence the health of families, and why are some community members healthier than others?
I'll go with the influence of the community. Um, uh, I found that in certain neighborhoods, there are different resources available to them. Even when you speak to vegetables and the foods that we eat, um, it's not necessarily a not diverse options available to them. And so some people have to venture out of their neighborhoods to get what they need. Others that don't venture out are then limited to just what's available in their environment, in the stores, within their communities, and out the neighborhoods and the areas and the communities need more diversity, more of the things available to them. And so I love the fact that I'm hearing a lot more about farming coming to communities and neighborhoods, and what y'all are doing here with providing those kind of resources. And so it does make a huge difference. They can't go out to get it. We got to bring it into them. I'll leave it at that.
Thank you.
It landed on orange.
Okay. Great. Well, if you see another question you want to answer, it's fine.
Forgive me my allergies. I didn't think I should even be. I'm the Family Success Center coordinator for La Casa de Don Pedro here north at 23 Broadway. Actually, I'm also a retired New Jersey State probation officer. I'm doing this work, but too young to collect Social Security.
And
We're La Casa de Don Pedro. You probably heard of us. We service people throughout the community. Whether it be programming, providing resources, baby needs, and community for rental assistance, high heat, low income energy assistance, so forth and so on. There's just so many resources and programming that La Casa does. Also, I'm going to include daycare, adult education, ESL, and more. I could keep going on. We'd be here all day. But members get in others. One is that the choice of foods. Because some people or some community members they eat a certain way because that's tradition for them. It depends on the culture. That's one thing. And then the second is I would say is that I want to piggyback off of Iris that the stores sometimes the vegetables or meats are not that fresh. So what other choice do they have? They don't have a vehicle to travel to another location. then I'm gonna also say the quality of the air. That sometimes the air can be kind of not so so good around here. I mean, I'm a former Newark resident. I was born and raised here. I'm just saying that sometimes I notice in the summer you get a lot of like smog, the pollution at the air, and it smells horrible. So people are breathing in these toxins. So that could be another reason why people are not so healthy. And then just I'm gonna include crime in that because if you're afraid to go out and just take a walk to get some exercise, then that's not gonna help. It depends on what section of town you live in, you may be able to go walk, or they may have a track, or high school football team, they may have a track, and some other areas may not have that. Or, like I said, people may not want to walk, take a daily walk because they're fear of being, robbed or something. So
Yeah,
that's what I'm
absolutely.
doing.
Good. All right. I'm gonna work on it via me over here.
The sticker doesn't like me. Thank you. Yeah.
Great and lovely together. She is in crime. So, in regards to this Health grant, anytime she needs assistance, needs help, or like needed to come in and scoop in to help, I'm always there to assist and vice versa. What's your line? Oh, it's awkward. So I have to just look, what does poor health mean? I believe in poor health, it could be in all, well, it could be in different ways. It could be like mental health, it could be like physical, it could just be like your overall body. So for like mental health, poor health could be like you're not, that you don't know how to basically handle and process certain situations mentally. You don't know how to express yourself, you don't know how to gauge certain situations. For like your physical health, it could be like, your nutrition could be bad. You could be like overweight, or you don't know like you don't have the resources or the education like what you should eat to make your body better, or you don't know what resource you could go to or access care. Like, oh, you have a clinic down the street, but you're not aware of it because you're not aware of your surroundings, or the environment could affect you. Like you say, you're scared to walk out at a certain time because you live in a dangerous neighborhood, and even though the clinic is something that's right there, you're like, I heard it's like a shooting or something happened over there, or I see people hanging out in the corner and I'm going to walk past that corner. So poor health could just be, I guess, in just all those aspects. Good morning. My name is Mike Arnold. I'm a doula slash case manager here at Mendoza Park. As well, my manager, so I was under her with this and the services and case manager, just helping the people. The right hand, right? Hello. Okay, how does parental education help infants? Well, basically, the question was answered, I think, but I feel the same. Like if they don't know too much, or if they don't know what to do with the baby, or don't have any type of like resources or education, they're not going to know how to keep the baby healthy. All around, both of them have poor health. So I think parental education is
Awesome. Thank you.
All right. Hi, good morning, everyone. I am Angela. I want to thank you all first for coming out this morning. I am the manager of this Catalyst for Infant Health Equity program. So I am landed on yellow. So I'll go with how does household income influence the health of infants? How money is everything, right? And you need money for food, you need money to pay your rent, right? So if you don't have a house to live in or a roof over your head, you don't have the resources to cook food, to eat, right? You're buying McDonald's, you're going to buy your cinnamon buns and all that stuff, right? So household income is very vital to our community. Absolutely. Oh, Charles.
I said, leave me alone. She said, no.
Um,
And why am I in it? Good answer. Good answer.
Not at all. All right.
Okay.
Thank you.
All right. Thank you all. Thank you all for humoring us and taking part in that icebreaker. I hope it got your thoughts running because we're going to be discussing infant health equity throughout the next couple of hours. So go to the next slide. I'm actually going to try to sit down because Melody sits down. This is weird. Okay. So I'm going to go over our workshop objectives and what we're going to do today. We're going to do three main things. We're going to understand, gain, and develop. So we want to understand key terms and concepts of health equity, infant health equity, and the social and structural determinants of health. We want to gain deeper understanding of the different types of structural and social determinants of health, as well as develop knowledge about downstream, midstream, and upstream interventions that improve infant health equity. Oh, you can picture guess. You can go ahead, you can go for it. We can actually give you the slides if you need to afterwards. Feel free.
Oh, okay. Did you get the picture? Okay.
Did you get your picture before? Oh, okay.
All right. Because we'll share who everyone has this first. And if she has your email address.
Okay.
Mhm.
Awesome. So as I stated in the beginning, we want to ensure that we're all working from the same definition of equity. So in January of 2021, the Biden-Harris administration released a executive order on advancing equity in communities. And so I'm going to read this verbatim so that we all have the same understanding to govern our discussion for the rest of the day. So what is equity? It is the consistent and systematic, fair, just, and impartial treatment of all individuals, including individuals who belong to underserved communities that have been denied such treatment, such as Black, Latino, Indigenous, and Native American persons, Asian Americans, and Pacific Islanders, and other persons of color, members of religious minorities, lesbian, gay, bisexual, transgender, and queer, also known as LGBTQ plus persons, persons with disabilities, persons who live in rural areas, and persons otherwise adversely affected by persistent poverty or inequality. So again, that is the definition of equity that we are using throughout our discussion today. I will tell you that in the federal space, whenever we develop a definition, that probably took 2 years to develop. And everyone got their input. So we kind of tried to make sure that we cover all people in that definition. So again, we want to provide you guys with more information on what is equity. So we have a short animated video that's going to share that concept of health equity and also emphasizes that everyone deserves equal opportunities and access. So Melody, can you click the video, please?
Yeah. Hold on. I gotta go out. Escape.
Oh.
Here we go. We're gonna have these little delays now and then just because we're going back and forth across different screens. But can we make it louder?
This is where the concept of health equity comes into play. Health equity is the idea that everyone, regardless of their race, ethnicity, socioeconomic status, or any other factor, should have the same opportunity to achieve their best health outcomes. However, we know that some groups of people experience better or worse health outcomes than others. When we talk about the differences in health between groups of people, we call them health disparities. These are simply statistics that show the differences in health and disease between groups. When these differences in health outcomes between groups are the result of conditions that are avoidable, unfair, and unjust, we call them health inequities.
Health inequities arise from systemic and structural factors that create barriers to accessing healthcare services and resources. Examples include poverty, inadequate housing, racism, discrimination, the lack of access to health insurance and healthcare resources, and lack of access to education and employment opportunities. For example, we know that due to racism, people of color are more likely to experience barriers accessing healthcare and are more likely to be uninsured, underinsured, have lower quality healthcare, and to face discrimination from healthcare providers. This can lead to chronic stress and delays in diagnosis and treatment, resulting in poorer health outcomes such as Black women are 3 times more likely to die from a pregnancy-related cause than white women. Latinx people have higher diabetes and diabetes death rates compared to white people. African Americans are 7.8 times and Latinx Americans are 3.6 times higher risk to get HIV compared to white Americans. And African Americans have higher rates of heart disease, diabetes, several types of cancer, and asthma than white people. It is avoidable, unfair, and unjust. Other examples of health differences that are caused by social and structural factors that create barriers to accessing healthcare services and resources include the diabetes rate is 15.2% for people living below the poverty line compared to less than half that, 7.5%, for those living at or above the poverty line. LGBTQ plus individuals are 2 to 3 times more likely to experience depression and anxiety than heterosexual people. Native Americans have a life expectancy that is 5.5 years less than the general population. These statistics demonstrate just how unfair and unjust these health inequities are. They are also avoidable because we can do something to reduce and even eliminate poor health outcomes. Unfortunately, over time the terms health disparities and health inequities have merged together. The concept of disparities was traditionally used by epidemiologists as a quantitative measure. In 2010, the Healthy People definition of health disparities focused simply on the numerical or quantitative difference in health outcomes between groups of people. The 2020 and 2030 Healthy People definition of health disparities was changed to acknowledge the systemic and structural factors that create barriers to accessing healthcare that contribute greatly to differences in health between groups, making it more consistent with the definition of health inequities. This is a great step forward in some ways. However, this new definition forgot to adopt the most crucial aspect from the definition of health inequities, and that is the aspect of being avoidable, unfair, and unjust. By not including the terms avoidable, unfair, and unjust in the definition neutralizes the aspects of health inequities that are most important and manageable. It also implies that people's racial or ethnic group, religion, socioeconomic status, or other characteristics are the reason why they are experiencing the difference in their health outcomes. Achieving health equity involves focusing on the unjust, unfair, and avoidable systemic and structural factors that are in place and perpetuated every day that keep groups of people from being as healthy as possible. We all have the ability to address the avoidable, unfair, and unjust. We should meet people where they are and address their unique individual needs. We can make health equity a reality.
Awesome. So that video clearly showed us that there are issues and reasons behind why there is health inequity. And as you all know, we're here to focus on infant health equity. So we want you to have that video in your mind as we continue our discussion. Next slide, please. So infant health equity is our goal, right? And so how are we going to reach that goal? What does that mean to us?
Okay.
Infant health equity means, should I pause for the people online?
Well, I timed out.
Okay. Commercial break.
Commercial break. Do you need this keyboard? Okay.
Awesome. Back to the regularly scheduled programming. So yes, infant health equity is our goal. So what does that mean? It means that we want to ensure that every infant has the best chance to live a long and healthy life, regardless of their social circumstances. Personally, that is something that I strive for, and that's why I get up in the morning. I know when people say, why do you do what you do? I always usually say, regardless of the circumstances at birth, all children should have the opportunity to thrive. So the question that we want you all to focus on throughout today is, how do we do that? How do we get to infant health equity? Next slide, please. Oh, no, it doesn't want us to come. Okay.
Of course.
One more. And then it's awesome. So here we are. This is the Maternal and Child Health Bureau's favorite graph on earth. And you can't really see, it's kind of like difficult to read, but this chart here shows the infant mortality rate by race. Okay, so you'll see the blue bars are different individual races, and I'll read them for you because you cannot see them on the screen. The first bar is for white infants with the infant mortality rate of 4.5. The second bar is Black or African American infants with the infant mortality rate of 10.6. The second bar is American Indian Alaskan Native with the infant mortality rate of 7.9. The fourth bar is Asian with the infant mortality rate of 3.4. The fifth is Native Hawaiian or other Pacific Islander with an infant mortality rate of 8.2. And the final one is Hispanic with the infant mortality rate of 5.0. I want to call your attention to that orange bar in the middle. The orange bar in the middle is our Healthy People 2030 target. So for Healthy People 2030, the target is 5 deaths per 1,000 live births. So that's what we want to achieve for everyone. As you see, under that bar, we have achieved that goal for white infants, for Asian infants, and also for Hispanic infants. But look where we have not achieved that goal. For African American infants, for American Indian Alaskan Native infants, and then also for Native Hawaiian and Pacific Islander. And I want to bring attention to that second bar, which is more than twice that of the goal. And so we know that there are some factors that are influencing that, and we want to work to reduce infant mortality for all. So we want to reduce infant mortality so that we can make it to that 2030 goal. But it's important to note that as we're reducing infant mortality for those who are the outliers, we're also going to be reducing infant mortality for the ones who are already under that bar. So then the bar is going to have to move even more. So again, just to be very clear, if we do make it so that infant mortality rate is 5 deaths per 1,000 live births for everyone, that means for Asians, it will probably be 1.2. It's going to continue to decline. And then we're still going to have inequities. So now we're going to discuss, and again, that's why we're here, to discuss how we can achieve infant health equity for all. Next slide, please. I'm turning it over to Melody.
Thanks, Rochelle. All right, so this top line there is yellow because that's actually a link to a video, and we'll show that video after I discuss this slide. This slide really is highlighting what we're talking about with respect to structural and social determinants of health. And so as we were doing our icebreaker, like I was assessing that based on the questions and your responses, you do have an understanding of what some of the social determinants of health are with respect to, do people have access to high quality health care? Do they have access to education? And is it high quality education? What is the neighborhood and built environment like? What's the social and community context? And, are folks economically stable? So when these 5 areas are what we consider the social determinants of health. But before we get there, we really have to focus on what was discussed in the video we just watched around structural determinants. And this is where we're looking at what are governing processes like over certain systems? What are our economic and social policies looking like? And what can be done to maybe adjust them so that they are more fair, right? And how are we going to finally address and hopefully get rid of racism, discrimination, bias, and segregation, because all of these structural determinants are impacting the social determinants. So for people, we understand that the experience of these social determinants of health look like, what kind of income they are bringing in. Are they at or below the poverty line? Is there any wealth generationally or not? What is the education status? Are they employed? Do they have access to transportation to get to the needs and the amenities that they have for the community? Housing, we know that it's very difficult to not live indoors, and we want to get to infant health equity by making sure that every pregnant woman, is properly housed, her children are housed. What you all are doing here in Newark around food security, ensuring that folks have access to good, nutritious food. And when we think about our neighborhood and built environment, like, are we able to reduce exposure to toxins? Are we able to bring in, green space that is safe for people to enjoy? Do people have access to health insurance so they can get the health care that they need? And, are we thinking about distance to services? What I love about some of our federally qualified health centers, like Newark Community Health Center, is that every services are co-located. We visited six, right,
20.
of the locations here, and what we loved is that dental is there, OBGYN services are there, pediatrics is there, mental health or behavioral health services are there. So if there are issues with transportation, they're great that folks in the community can go to one location and get their health needs. So this is what we're talking about. Like, are these things in place? How are these things impacting overall health and wellness? All right, so I'm going to go back out of this so I can show you a video that it's actually done by HHS, our Rear Admiral Levine, and they are just further explaining the social and structural determinants of health. After this, we only have one more video, so we won't have to click out of this.
Social determinants of health as the conditions in the environments where people are born, live, learn, work, play, worship, and age. Social determinants affect our health, well-being, and contribute to health disparities and inequities as well. Healthy People, our nation's longest-running disease prevention and health promotion initiative, emphasizes addressing the social determinants of health to create environments that promote health and well-being for all. I'm Admiral Rachel Levine, Assistant Secretary for Health at the United States Department of Health and Human Services. Healthy People 2030 provides a framework for thinking about the social determinants of health across 5 domains. Here are 5 social determinants of health. First, economic stability. People with steady employment are less likely to live in poverty and more likely to be healthy. By helping people earn steady incomes, we can achieve economic stability for all. Second, education access and quality. People with higher levels of education are more likely to be healthier and live longer. By helping students excel in school, we can improve educational access and quality. Third, healthcare access and quality. Many people in the United States are unable to get the healthcare services that they need. Increasing access to high-quality healthcare services will ensure more individuals can attain their full potential for health and well-being. Fourth, neighborhood and built environment. Health and safety risks, like high rates of violence and unsafe air or water, impact health and quality of life. By creating safe communities, we can provide opportunities to promote playing and physical activity. And fifth, social and community context. Increasing relationships and interactions with family, friends, neighbors, and community members is beneficial to an individual's health and well-being. To learn more and see how others are working to address the social determinants of health across the nation, please visit healthypeople.gov. U.S. Department.
All right. So we kind of drilled it in, right? Like at this point, does anybody not understand social determinants of health? Everybody feel like they have a pretty good understanding of like what those 5 domains are, and how it may impact health for an individual as well as the overall community. Very important. I feel like in the time that I've been in federal service, it maybe just the last 6 years have in the work that I've done, and I've worked on a lot of programs for communities that we've really been kind of underpinning all of our programs with this type of framework, right? And I think it's wonderful. So this is how we, get to better outcomes for not just infants, but for, the population. We have to focus on improving these for everybody. So here you're going to get some more examples of social determinants of health. I pulled these out because I feel like these are really specific to what you're doing here with Newark Community Health Center and your Catalyst grant, right? Particularly with access to foods that support, healthy dietary patterns. I'm not going to spend too much time on this, but I just wanted you to know, like, this is a resource that you can find on the Healthy People 2030 or Healthy People website that you could print out. You could use these to try to inform other folks about what it looks like when we're talking about food insecurity or food security. Like, the availability of healthy, fresh food, the cost, like, is it affordable to the people in the community? Do they have access to transportation to even get to it? So if they don't, you're thinking about, well, what can we do to bring that to them? What Newark is doing here, we see is like you're doing your farmers markets so that folks in the community can maybe just walk to get the food that they need, the healthier foods that they want. And then what I also like is that, even though it's not specifically called out, like when we're coming together at the farmers markets, like I had a chance to witness one yesterday. There's opportunity for engagement and interaction. Like folks are talking to each other. There's other community vendors there that are also focused on health and wellness. Maybe it's not specifically food, but you have the experience of sound healing, which I had a chance to receive yesterday. There were people who were, just showing folks how to stretch, just in the chair. Like all of these things are supportive of health, right? So it's coming through your, program that's giving people better access to healthy foods, but it's also, bringing people together, right? So hopefully improving their well-being because like now there's a place in the community where I can meet other folks, get access to some other services. We saw that, some of the products for menstruation were there, so your partner here, they're well represented. So we love things like that. It feels very holistic, right? Um, and then I pulled this example, right? Access to health services. So what you're doing here when you had your Healthy Start program, right? As well as with Catalyst, as you're doing outreach, like just making sure people can get health insurance, signing them up for Medicaid, you know, the fact that they're community health workers that are, signing up for resources, but also making sure that they know about services available to them, bringing them in to get the care that they need, even the ability to have things like telehealth improve access to healthcare just because there are folks that may not like we know this from the pandemic, right? You still need healthcare, but you can't go to it. So now we have telehealth services. And particularly, I think it improves access for all in a way that brings in technology and innovation. And I love that too. Folks that don't have transportation, they again can do what they need to do through telehealth. So, like I said, these examples, they're on the Healthy People website along with others. You can print these out and share them as needed, just to make sure people know that like in the federal government, we're doing things that are being more mindful and holistic to what really impacts health outcomes. And then as you in your programs are sharing with others, you could be thinking about like, okay, well, which SDOH am I addressing? Am I assessing for this? Do I understand it? Do the people we're working with understand it as well? Okay. So this is about infant health equity, and so I think it's important to think about like what are the impacts on on infant health of social and structural determinants of health. And we've talked about it already during the exercise, right? Like I think we have a good understanding, but here, I wanted to highlight as it relates to some of the work in Catalyst is that some of the impacts are related to, racism, right? So let's just say exposure to interpersonal racism and discrimination. We know that it is associated with poor birth outcomes, right? What might that look like in action? So, what if it is the healthcare provider not believing the pregnant woman of color, or she is saying, like, oh, I am in pain, I've been in pain, and here I am in my last trimester, and they're told, oh, you're fine. Or maybe that provider is thinking that, well, fat black person can deal with the pain. They don't need any medicine or whatever, or they're sent home with nothing. And then it leads to, maybe a preterm birth and maybe even a loss of a pregnancy, right? This is what we're thinking about when we're like, what is that impact? And this is like a structural determinant of health where if there is implicit bias, if there is racism and discrimination within that provider, now that pregnant person, that infant does not do it, right? Um, we talked about housing, and we know historically there's been redlining and housing discrimination, segregation, um, again, a structural issue, a policy. Redlining was an actual policy where people could not live where they needed to live, right, or wanted to live. And maybe it left them in communities that were high crime, left them in communities that did not have access to the resources, that was maybe in an environmentally toxic area. And so now that infant, is exposed, right, maybe to lead, right? And we all may have an insight on what lead exposure does, right, to children, to people, right, in general. Like, but where we see it in infant health is preterm birth, low birth weight, and then infant mortality being high for Black infants, as Rochelle said before, for American Indian, Alaskan Native, and then our Hawaiian and other Pacific Islander populations. Again, these are some of the things we are trying to address with our programming within Healthy Start, as well as Catalyst for Infant Health Equity. And then finally, economic factors such as income. I think, Angela, you had answered that question where it's just like, if you don't have money, if you don't have a job, if there isn't any, let's say, generational wealth where you could say, oh, my parents are going to, help us get a house, or they're going to like give us things for the baby, or you don't have those kinds of resources in your life, right? Those are all associated with poor perinatal outcomes, right? And what we'd love to see is that, maybe programs that are doing things to help people get employment, right? And then also grow wealth. And I think, wealth generation in this country sometimes is tied to housing, because if you have a home in the family, right? That, home oftentimes for a lot of people is where, you have a major financial investment that maybe can be passed on, get a second mortgage if you need extra money, things like that, that people who, are housing insecure don't have access to, right? And all of that impacts their ability to have financial resources. So we have a lot of our Catalyst programs that are focusing on housing as well, because it's so important. All right. So now we're going to move into just talking about some strategies to improve infant health equity. And here I've highlighted 3 types of approaches or interventions. And so a community-based approach where, you're engaging the members and people with lived experience in the community, to inform them on infant health equity intervention. So this is just like the outreach, like, hey, we're doing public awareness, and then we're asking you, just like how you all have come today, you're either working in this community or from this community. You've come today to just learn about what is going on with respect to infant health equity activities here in Newark, right? So that's one community-based approach. The community health worker program, when I love them because oftentimes some of the community health workers are from the community, right? They are representative of the people they are serving in the community. We have seen in some of our programming where, let's say if it's our Healthy Start program, participants love it so much, they benefit it so much, then they want to go on to become community health workers or like peer support specialists themselves in the communities that they live in. Community-based doulas, also a very important community-based approach because they know the resources there. They know the people there. There's a level of sometimes trust that a community-based doula will have with the pregnant person that sometimes the provider doesn't. And we love to see those types of things, as well as the community-based support groups. And this is just like people coming together. Let's say it's a postpartum support group or a group for dads, even for siblings, right? So that, again, you're focused on that social and community context, bringing people together. They get to resonate with each other, sharing resources. We like to see those type of approaches. And I think they're helpful, particularly for infant health equity, because um, the saying, it takes a village, right? But it puts the community, I think is a similar interpretation. So let's move on to healthcare interventions. So I think it was Tuesday, and we had the workshop with Dr. Like on cultural competency in infant and mental health care, and I'm sorry, maternal health care. And he spoke about culturally respectful and responsive care. And this is, let's say, I never think that anyone who's not of a particular culture can be completely competent in someone else's, but we can definitely be respectful and responsive, right? So asking questions before making assumptions, particularly if someone's culture, doesn't align with yours, and you're like in a position of power because you are the provider or you are the one for offering the resource, just pausing to think about that and ask, like, well, how do you do this type of thing in your community, or in your culture, when it comes to safe sleep practices, or when it comes down to breastfeeding, like what's been helpful. Just being aware of that is important. Another thing we like as a healthcare intervention that is supportive of improving infant health equity are medical homes, the integrated care models, like what we see in our federally qualified health centers. Making sure everything is co-located, I think, is brilliant, because it's just like, who doesn't like a one-stop shop? It's why malls used to be so famous and popular, because everything you need is there, right? And then also centering pregnancy, I think, is another great way to improve infant health equity. Here you have group-based prenatal care. The pregnant people come in together for their care. Not only are they forming a support group for each other, but it's almost like it's I think, a situation where each one of them are reinforcing the good habits, that can be developed, that they get through that group-based prenatal care. So very important healthcare interventions that I think can, be integrated in a way that are inclusive of the voices of the people from the community too, right? So asking them, like, if you're in a centering pregnancy type of program, like, what from your culture and community would you like to see in it, right? One of the things we really promote in the Catalyst work is people with lived experience, having a voice, not just like showing up, but having a say in how this work goes, right? Offering their ideas, and then us, not as the providers or the funders or the program people, not just kind of taking it, but really reciprocating and providing them with pay, or an incentive for what they bring. As we move on to policy interventions, well, universal health care coverage would be great. But what we did get was some Medicaid expansion, right? Which has been helpful, I believe. Some states have moved the needle forward by extending Medicaid access in that postpartum year, which is, wonderful because that fourth, what do you call it, the fourth trimester, right? A lot of things can go wrong, but also go right if you are getting care that period as well. So that's sometimes that takes political will. It takes our legislators hearing the stories, right, and knowing their constituents in a way, and the data, and being able to share that data in a way that they're like, oh, okay, like if this is what's happening in my state, like what can I do as a legislator to move the needle forward so that we can expand Medicaid in ways that improve infant health equity. And then, of course, maternal and child health programs, right? Like Healthy Start, we have HV, which is our home visiting program. There's programs like Project Launch out of SAM. So there's so many programs that are at the federal and state and local level that had to take a policy to get into place, right? Someone had to authorize money, somebody had to make an act. But a lot of times that doesn't happen until folks in the community raise their voice and say, look, this is what's happening here. And we want our tax dollars to go to that. So that's a different level of work because it does take some advocacy, but that's how we get to real systems change, when we can have a policy intervention that is focused on improving infant health equity. We're looking at data, we're looking at ways that maybe we're saving money long term, right? Because it's expensive to be sick, right? It's expensive to our country, when the youngest and the most vulnerable don't grow up because they don't live, and now like we don't have enough people, or we just don't have the things that could improve everyone's life, because we want to be thinking about the lifespan. So we want to start with our most youngest and vulnerable all the way through the end of life. So those are the types of policy interventions that we currently have and that can be thought of. So I want to just pause because I know I've been talking a lot. I want to just see if folks have any questions.
I actually wanted to, I don't know if I'm jumping ahead, so I asked for what we have, what other slides we have. But as far as like the accessibility, I feel like the stores and the food, like the restaurants and the things that people can obtain for themselves and their families, I feel like there's a big difference in the unhealthy prices
Mm-hmm.
and the healthy drugs.
Hmm.
And I feel like should be easier to regulate a little better where healthy food is a lot more expensive. Organic and vegetables
Mm-hmm.
all are more expensive than more. That was regulated a little bit different. We could afford the healthy things, not just it's like snacks and just
Well, I so agree with you on that, right? I think that just takes a sea change in thinking at like the corporate level, in terms of the businesses and corporations that, put these products out there, right? I mean, you're talking about economic policy changes that have to happen, but could happen if, let's say there's a groundswell of folks who are like, okay, I'm going to educate my legislator about how it's just unfair. Like so many people don't have access to organic foods, and we want to make sure there's something or some way that these prices can come down. Like we know like our federal government and the businesses do work together in ways that I'm not going to go into detail here.
Actually,
You know, but you know, if I just feel like if there's enough people who are making enough noise about these things and, you know, in different ways in terms of how we spend our dollars, there can be change, right?
yeah.
There can be change.
I actually have an example of that. So in 2009, the Women, Infants, and Children program, so WIC, enough people made enough noise, and so they introduced the Fresh Fruits and Vegetable program. So prior to that, WIC vouchers were not able to be used to purchase those types of items, and so during the Obama administration, the first go round, that was introduced, and it was because people made noise. So, like Melody said, the more noise we make about the things that matter to us and so that we can have positive outcomes, things can happen. But we need to work together to do that.
Yeah. Sure.
So regarding the structural return of positive events to education, because we're doing a lot of work on the other with the students, but how about the education aspect as it relates to first the federal government?
When you say education, do you mean like traditional education? Mhm.
Children, adults, the point I'm trying to make is any work being done looking at access to education as one of the SDOH that you're aware of.
I would say, okay, yes, right. So we're not Department of Ed, right?
Yeah.
First of all, when you think about how schools are locally controlled, right? So this would be like a local level kind of issue, looking at, you know, your, I don't know how it is in Essex, but let's just say like where I live, it's the county Department of Education that is looking at, you know, how to fund schools, right? So in that you're thinking about like where you live. Do you live in an area that has like good schools, and are they considered good schools because the tax base is high there? They have a lot of programs and things of that nature. So, you know, if we're talking about public education, right, just remember like schools are locally controlled. Out of the Department of Education, where they're setting policy or they're providing funding for, you know, like um, certain populations, like our Title 10 population, Title 1 schools, you've heard of
Yeah,
that, right? So, you know, that might be going to the schools that, you know, are really high need, right? In terms of like, oh, you know, the population there is getting like free and reduced meals and things like that. And so not necessarily like directly impacting um, access to education. You know, a lot of that I think is kind of more grassroots in terms of how are you talking to or reaching out to parents, families about like what do their children need? Are there programs like after school programs that are being supported, things like that? So I have an understanding of it from that perspective, like as you know, you go through K through 12, right? Like just what types of resources are going into the schools. And if there is work that you're considering, maybe like partnering with the school to make sure like certain types of programs get in there. Again, locally controlled. Sometimes there are some federal resources there. I mean, like Rochelle
Yeah,
used to work
I was
in
gonna
Head
say.
Start, and you know that's a huge federal program, but it's still very community based, locally controlled, right? When we get into higher education, I think that again you're looking at our high schoolers being informed about like educational choice options. College may not be for everybody. You know, we still need people that get into the trades. Is that being promoted in a way that they know like, hey, you know, maybe you can go to community college for free, right? Or at a reduced rate. Sometimes people just aren't aware. So again, it's like how are we raising awareness of what is out there for them to participate in, and then also, you know, assessing for what's considered high quality and is there a pathway to employment for some of the type of educational choices that people are making. So there are federal dollars. A lot of times this is coming through Department of Ed. If it's like early childhood education, you're looking at Head Start was coming through the Administration for Children and Families, things of that nature. So if we're really looking at like infant and early childhood, there's programs through SAMHSA, which focus on like parent education, and then like the very and there's McVie too that is also looking at parent education. There's components of let's say, social and emotional development support in some of our federal programs. But again, I would say, how embedded are you with the local school board in terms of like what do you want to see in the schools? That there's a pathway, right? I mean, we'll deal with early literacy and things like that because, we understand that when, let's say, a parent can read to their child and the child is, ready for school, we have support for that. But again, the dollars will come down from the federal government to the state. The state is giving it to the counties or, the jurisdictions, the local education agencies. And then at that point, it's local school boards that are making those decisions.
Thank you for
Mm-hmm.
that. It makes me think about the work that also engage in different community-based organizations and being very diverse and who comes to the table and having conversations because I think that we don't know sometimes who's sitting around the table that it might spark to then, oh, we didn't think that way. But all this, social determinants of health in a way that they're sort of linked to each other, definitely to education, starting at an early age. So really, engaging community, a diverse group of community organizations, education and so forth is very critical because it can, help us to have a stronger voice and also to give the individuals a voice as well.
Yes.
I want to add something. I work a lot with kids, and I had a mentoring group in East Orange. And one of the things that I introduced to the group was healthy eating, because if the children ask, the parents will provide.
100%.
Yeah.
And that was every month I needed to submit an agenda, and there was nutrition in there at least twice a week. And I did it for about 11 years, and I had multiple family members there, and I saw these chubby little kids go from being not so chubby little kids to family members talking to me about how they've changed their diets because, and I advocate this everywhere I go, your food is your salvation. What you put in your body is what, keeps you going. But it's not just early intervention, you have to continue to bring it because, Doritos have this cool commercial. So people get, seduced by these commercials, and it's exciting and fun and trendy. So I want to be able to talk about that. But let's kind of, anytime we can, kind of pivot and share. You know what? Taking care of ourselves is also exciting. So that's my 2 cents.
Thank you.
Yeah.
I want to add some what you said earlier about affordability and access to food related to grocery stores. I know it's more of a business aspect, but what I feel also contributes to lifestyle choices is the placement of foods in the grocery store, especially at the checkout counter.
Yes.
I've never seen like fresh produce or like bananas or anything at the checkout counters. All I see is chips and candy. So I think that as well contributes to dietary health.
Yeah. That last minute choice to grab a Snickers bar. Right.
I'm hungry.
Yeah.
Yeah, that's a good point. I want to move on if there aren't any other questions or comments. Mhm.
And that dish with water with the land.
Mhm.
So I'm thinking that maybe with the infant mortality rate, that with the mom ingesting the water with the leg, that could affect the child. The child survived the
Mhm.
now they're in school. They should be maybe in preschool, kindergarten around now. That could affect their learning ability.
Absolutely. Absolutely. Right. And that can be a soft for with a mhm.
So here in granted, not just because of SAT, but there are requirements that we have to check our children for lab. And of course, if we find it, it needs to be treated. And so in North, they're doing a lot of revitalization where they take changing out the pipes. No more lead paint scheme that we order buildings. Definitely, lead paint.
That is like a perfect example of like a midstream and the upstream intervention, which we're going to talk about in a little bit. So thank you for sharing that. Right. So I don't know if anyone is familiar with the Bay Area Regional Health Inequities Initiative. So I really, this framework is excellent because I think it really is good in terms of like showing you what we were just talking about with respect to structural and social determinants of health, and then also explaining like upstream to downstream types of interventions or like activities in the public health framework. And then also, if you are thinking with a public health mindset or looking at this with a public health lens, just what are some of the emerging public health practices that we're doing now that get us upstream, and also what we're doing now that is more downstream but still needed, right? So I don't want you to think when we get into the discussion around like downstream, midstream, upstream activities that address infant health equity, that downstream is bad or not necessary. It is. That is like where you're getting people into critical care right away. Like somebody needs a doctor's appointment, they get a doctor's appointment and go because they're not feeling well. But if they weren't feeling well because they didn't have access to food that was helpful, you're doing something like here with the food farmers market, that's a living conditions type of issue that is at the midstream level, right? And then if you're really going upstream, maybe something like what Hari suggested around like a store actually changing its layout, right? And all stores changing their layout so that the first thing you see, are fresh fruits and vegetables. Um, I think most grocery stores you kind of like get hit with, at least where I am, like all of the box things, right? And then like meats, dairies, fruits are kind of like on the outlier, you know, of the store in terms of if you look at the layout, like it's in the back or it's on the side. And then like front and present in the center, all the processed things that, you still may need to eat, but they're usually not as nutritionally dense as what's on the perimeter of the store. So if we were to change that, we're starting to go upstream, right? And then what if like it became law, right? Or, a policy, right? We're going further upstream so that now it's like that in every grocery store. So this framework just kind of lays it out in a way that I think is very helpful because it helps you to see social and structural determinants, right? And the types of things that go from, of health rather, that go from downstream to upstream, um, underpinning it with policy all across the board. Because even for downstream types of activities, there can be policy related to like how do we do a well child visit, that brings in more justice, that is more equitable. And then how do we ensure that this is happening everywhere so that now we're addressing social inequity. So love this framework. Like I said, you'll get these slides, but if you ever go to that website for the Bay Area Regional um, Health Inequities Initiative, it's there and they have a beautiful explanation of it. Okay. Right. So here I want to talk a little bit more about downstream, midstream, and upstream interventions just to you know, further ground you in what we mean by this with respect to infant health equity. So a downstream intervention would be like us just increasing equitable access at the individual or family level to health and social services, right? So you all do that here, right? Like you provide healthcare to people, you provide social services to folks in the community. And this is where you're looking at changes that are occurring at the service level or access level. Very important still because we need to do this. And it's just more about like changing the effects of the causes. So like someone's sick, um, and they go to the doctor. We need that. We don't want to change that at all. But it doesn't really address root causes. Root causes we start to address at the midstream and upstream intervention level. By midstream, we're looking at reducing exposure to poor perinatal outcomes. And this is when we're starting to improve like the material, working, and living conditions. So, maybe someone is doing a project that improves green space, making it safer. Um, Someone is doing like what you all are doing, having a farmer's market to bring access to healthier food options, showing residents like if you've never worked with kale or cauliflower before, like this is how you make it really tasty with herbs and spices or whatever, like showing them like this is how you do it, right? And this is kind of more at the local micro level, right? But midstream is also like what Dr. Shaw talked about with respect to the lead here, right? So in Newark, if they decided, at the local government level that we're going to go into older apartment buildings and homes and do lead abatement, right? Changing out the pipes, making sure there's, no lead chips for kids to eat on or whatever. Like, so now you're looking at a policy change that may have come from the city and other actors, like the Department of Housing or public works that is involved in doing that action, right? So it improves a perinatal outcome because now like that family, those children, that individual is no longer exposed, right? So we love those types of things too, and this is a change that is at the community and individual level, right? So we go further upstream. And I'm going to stick with the lead example because this is where you're doing like a fundamental change or reformation to like social and economic structures related to how we deal with wealth, distribution, uh, discernment, and things of that nature, right? So let's say with the lead abatement within the state of New Jersey, right? Like the government there decides to change that policy that like when we do any new housing development, right, like we are going to make sure that it is affordable, that if everything is going to be, I think they call it LEED, LEED, where it's like environmentally appropriate or at the highest standard, right? And because it's new development and we know housing is an issue, we're not just focused on putting somebody in a house, we're putting them in healthy housing, right? And this starts to change the dynamic in terms of how we think about how to do housing, right? Thinking about like, hey, we're not going to do like low quality things anymore. We're going to go very upstream to the point where it becomes a state policy. All new housing has to have these types of, things in place so that the families that move into them, will be healthy in the housing, right? And that is more systemic, right? And then if they go even further upstream to say, and this is addressing not just the environmental aspect within that neighborhood or within the state, but also it's impacting housing affordability, right? Now people can be assured that they have a place to live that's affordable as well as healthy. And we don't, just say, oh, we're only going to do it for 5 years or 10 years. Like this is how housing gets done all the time, and it becomes institutional, systemic, like it gets embedded into how all of it is created, right? So that's very upstream in a way that, you're looking at, oh, the next generation, is going to benefit from this as well, right? And so this is more at looking at the, systemic or structural causes of the causes, right? And that's where we really want to get to if we're thinking about, you know, accelerating the reduction in infant mortality rates for the populations that have the highest rates when we're thinking about these social determinants of health holistically, right? So yes, you could just focus on, environmental things, but why not focus on like environment as well as housing affordability? And sometimes these things lead to, like if you think about housing development, what sometimes comes with that. I know where I live, when the new housing is built, new shopping is built, and it always features a grocery store, it always features maybe like a daycare, because businesses are thinking about, oh, look at all those hundreds of new homes over there. They're going to have families in it. So, like, if we want everybody to benefit from it, we would put all those resources in place and we'd make it affordable for families. We'd also think about transportation, right? Because folks need to get about. Sometimes the housing gets developed in a way where you have to have a car to be able to get to it and then get to and from work, right? Could we do transit oriented development, where there's the housing, there's transportation, there's services, and it's done in a way that's at the highest standard in terms of, environmental concerns, so that they're not using cheap materials. Everything is new, everything meets a standard that is, conducive to good health, right? So that requires, macro policy level change, right? And it is doable. The will has to be there to do it. It's not always just going to be about the federal or state government, initiating it. It is also coming from like a grassroots push for it, right? People saying like, this is what we need and want, and there being some money behind it. So, and I think that's where the federal and state government and the government come into play. All right, moving forward. So one of the things we didn't do, and I wanted to make sure we got it in here, was just really talk about this Catalyst for Infant Health Equity program that is coming out of HRSA. So we've been thinking about this for a while. Like I said, I've been in federal service for some time, and with each new program I work on, there's more and more of a focus on, addressing disparities, improving equity. And since I've been in the Maternal and Child Health Bureau at HRSA, it's focused on, reducing disparities for perinatal populations, right? And improving things for infant health. And I love that the framing of it is around these social determinants of health. So in September of 2022, when we put out the NOFO for the Catalyst for Infant Health Equity, and the NOFO is our Notice of Funding Opportunity, it was to all communities, right? We didn't just say it was going to be for Healthy Start, even though the money comes from our Healthy Start program, but for all communities, even if you didn't have a Healthy Start grant before, because we wanted to look at communities getting funded that had these high infant mortality rates, and the goal of the program is to be able to reduce infant mortality based upon implementing an action plan that is addressing a social determinant of health, right? And now that we know what those social determinants of health are, um, anyone that applied had to at least focus on one, right? And show us that like you had this high infant mortality rate, but you were also going to implement a plan that helped to reduce the rate based on addressing the SDH, right? And so again, our goal is to continually reduce infant mortality overall, just as we said before, not just for those that have the highest rates, but for everybody. And then hopefully, ultimately, eliminate or just I don't know if we can eliminate, but let's just say reduce the disparities across the racial and ethnic groups that have the highest rates. So that's why we did Catalyst for Infant Health Equity. We ended up with 9 grantees. The majority were organizations that HRSA had previously funded through Healthy Start. And all of them are working on different SDOHs, and they're across the country, with the majority of them being like on the southeast. So we have several in Florida, we have Newark, we have one in Pittsburgh, we have one Baltimore. So we have housing. Some of them are doing like a focus on healthcare access with having navigators and co-located services. And so we're learning a lot from this program in terms of like if there are some resources to implement a plan that goes upstream enough, what will we learn from it? What will people do with this? Like how will communities benefit in a way that reduces overall infant mortality? So I wanted to give that framing. So, and there's a lot of content to take in. So if folks need to like, take a break or whatever, please do so. We will do a break like right before we get into the activity of, you all coming up with your own midstream and upstream interventions. But if you need a break right now, or just take it as you need to, okay? Um, so here I wanted to highlight just what catalysts for infant health equity midstream efforts have been like from some of our current programs. So understanding that midstream is at that community or individual level. We have programs in Baltimore. So our Catalyst grantee there is focused on like addressing housing, right? And they're doing that through like a housing university, right? They're also looking at, employment too. So one of the extreme activities that they're doing is computer skills training through a partner that once those folks have the computer skills training, like in cybersecurity and coding and things like that, they are given a pathway to a job, right? And these are jobs that pay well, jobs that are now addressing, the economic disadvantage that that community was experiencing, or people in that community were experiencing, right? We have another grantee that's in Broward County, Florida. They're focused on, their midstream effort that's focused on healthcare access. They're doing what prenatal care, but it's co-located, so they're in a family health center that has the integrated care model, right? So everything in one space. We also have another Catalyst grantee in Ohio, and here they're going midstream. Their midstream activity is focused on addressing just housing in a way that I can get to that like that other. I think it's on the other slide, but they're in Ohio. They're doing work where they have Black women who have lived experience, and they're working with their community health workers in the prenatal clinics, right? And this is helping to diversify the prenatal healthcare workforce. And it's also addressing racism and discrimination because when they were doing their assessment, the the reality for them is that like those Black women are not represented by the providers. And so if we can get them trained as community health workers and they're in those clinics, then they can be advocates, right? And support. And they're also getting a pathway to employment, which, again, addresses income. In Newark, we highlighted you all with your work around the food markets, right? Like the coordination of the farmers market, helping people make healthy food choices, doing the food demonstrations, again, a midstream activity, right? And then finally, we'll talk about Bloomington, Indiana. This is the University of Indiana, and they have this program where they're focusing on doing legal analysis and providing um, information and publications like court-based advocacy to improve housing stability and quality. So there's a model that's like looking at a medical legal housing approach so that people who are, let's say, medically compromised in some way can be advocated for to maintain housing while they're not well or while they're pregnant or whatever, so that they don't get put out and be further harmed. So that's been a really interesting program, and they're doing some great work there. Again, midstream, because it's more about like raising awareness by them producing the legal analysis and publication documents, but also this court-based advocacy that they're doing is keeping people in there. So that's what we want to see. So as we go upstream a little bit more, we have some more examples from our Catalyst grantees. Again, the same grantee in Indiana, they're using litigation to keep people in housing and also to improve the housing conditions. They're also looking at like how to realign incentives in a system-wide way to have high quality housing. They've developed a Know Your Rights educational materials that they're sharing, not just with people in the community, but also with other lawyers and folks in the court system. And they've done, a really good job of kind of connecting the dots to like housing and how that impacts like the first 1,000 days of child development. So it's been an interesting program there. Our grantee, again in Ohio, is providing ongoing training that's relevant to areas of maternal and child health, such as health literacy, lactation consulting, perinatal support, doula care, and then like using the CHWs or the community health workers to connect them to other resources and like mentoring, home buying, credit literacy. And again, this is the grant here. They've been able to not just address employment for the people with lived experiences who are the community health workers, because they're getting trained and they're getting these jobs as health workers, but they're also doing a lot around health literacy and some racial equity assessment processes. And another grant that I work with, Baltimore, the way they're going upstream is they've created a housing university, and it's in partnership with the landlord that they're working with. And basically, it's like, how do you be a good parent, right? And how do you be a good when they put on a symposium every year to share this information, and they're having tenants who uh, go through the certification, they can use that to get housing, because the landlords who will accept that certification, even if the person doesn't have like the best credit and things of that nature, maybe they've been evicted before, they can now say like, well, I went through the housing university program. This Baltimore Healthy Start program is vouching for us. I'm also employed because I went through their job employment training program, got computer skills, and I have a job. So all of that's connected to keep that person housed, right? And I love that approach. Baltimore's doing a really good job there. It's another one of my grantees. So now you have a better understanding, hopefully, of what we're talking about with the midstream and upstream approaches. And again, it's not to say that we don't want the downstream things of just getting people into care, because that's the start, right? We continually want to go upstream in a way that addresses some of these systemic barriers and structural issues. Let me take a pause and a sip of water. I've been talking nonstop. And also allow for you all to respond, because again, it's a lot of content. But I think it's important content, especially for folks that are doing this work. Okay. Any questions or comments?
Sorry. I'm sorry, my brain is, this is so impactful, what you're speaking of. It can really change the declaration, work that's being done. In 2022, but were there catalysts before?
No. No.
Then, in terms of the different aspects of the work being done, once the time frame is through, those changes can extend over different counties or different states. Is that the ultimate plan?
Yeah, hopefully, yeah, that is the goal. Like you would be able to sustain your work. Like so, I mean, it's a 5-year grant, so it's not going to like, give money forever. But like, hopefully, with the resources you have during the grant period, you're partnering in a way that you can sustain the activities that you started. You're also hopefully maybe getting to maybe at least a community level policy change or systems change that gets embedded into the system. So, for example, somehow maybe you're able to, partner with the local farmers that have been supporting the farmers markets to say like we're going to continue to do this, right? And we'll find some additional funding maybe through like I don't want to say another grant, but like let's say you get additional funding because you figure out like how to make it affordable as well as profitable for the farmer to continue to connect because maybe it has allowed them to to do so many more farmers markets that it's like okay, this makes sense for our business, right, to keep doing this, right, because we're getting money for it, right? So we're hoping that you'll be able to sustain what you started by embedding the work into the community.
I thank you for that. I'm also thinking further in terms of, so it's input mortality, right? So we want to work to decreasing the mortality in all the groups that you listed there. The idea of different places doing these different catalysts, how to, my thinking is how to expand it beyond, and spread it so that all of these different aspects can have these things that different communities have been working. So even just saying the housing discussion, how do you bring it now to North Carolina? How do you bring it to South Carolina? How do you spread it? That this is now a model that can go across the country to reduce things that might. So that's where my brain is taking me. Because I think it's so important. It's very good, consistent, and it's all over, so we can move on.
So I don't know. You want to talk about Healthy Start?
Sure.
Yeah. Okay.
Um,
24.
so I guess I'll start with and I believe they had the supplement as well, right? Here? Did you guys have the IHG
Yeah,
supplement?
they did.
So, and I think that was fiscal year 2021, right? So Healthy Start is our main program within the Division of Healthy Start and Perinatal Services, and it is the HHS program to reduce infant mortality. So in FY 2021, we had a supplement. So our Healthy Start grantees could go in for that money in order to create action plans. And so that kind of birthed into the Catalyst for Infant Health Equity. And I believe this grantee, as a Healthy Start grantee, had an action plan. They were to select a social determinant of health, and then they were to implement that action plan. Then we had Catalyst. After Catalyst, we had Healthy Start Enhanced. And since then, we have included action plans in all of. So now we have 115 Healthy Start programs across the United States, and they are located in the areas with the highest infant mortality and adverse perinatal health outcomes. So they're basically little catalysts inside of Healthy Start. Yeah.
Well, let me add that it doesn't require just a Healthy Start grant, right? So I think we actually or some type of coalition that wants to do this type of thing. Like, I mean, Nurture New Jersey, your state's plan is very, like we learn from that, right? Like, okay, Nurture New Jersey is trying to reduce infant mortality. Like, let's see, how they're doing it through food security by improving access to healthcare, by, getting people enrolled into insurance. And so it's looking at all, like we looked at like what was already out there before we were like, oh, let's do this, because we knew that communities and states were thinking in this way. Like I said, like for us, we have been seeing that over the years. There's been more of an emphasis on a more social ecological approach to addressing infant mortality and improving perinatal outcomes for all populations. And so what we did was just say, like, well, we know there are certain populations that have the highest rates, and we'll hone in on there because, we know when we get those that are most vulnerable, we're actually going to end up supporting everybody. And so, yeah, it, yeah, there's a lot going on, and I would love to see it in every community. Mhm. I'm gonna check this because am I locked again?
Work last time.
I know. Okay, there we go. Mhm. All right. Um,
While you're doing that, I just have to, I don't think we've said this since we've been here. I think we may have talked to you, Angela, about it, but our current administrator for the Health Resources and Services Administration is Carol Johnson, and she was the commissioner for the state of New Jersey's Health and Human Services. And so all of the programming that you see that's coming out of HRSA is literally coming from her mind, and it's all rooted in what happens here in New Jersey. So the community-based doula supplement, all of the new things that are coming out, those are her babies, and she's bringing them from New Jersey to everywhere else. So I just want you guys to know that New Jersey is at the forefront.
yes. All right. So, I just want to do a little temperature check and a time check because I know we are almost at noon, right? And this last activity is about 15 minutes, and I want to know if like people really needed to like leave by noon, or if they really needed to like get up, take a break before we do this activity. Um, Let me know so that I could, move us forward accordingly. Are you good to like just go through this right now? Do you want to take a pause and come back to it?
Maybe a 5-minute break to go to the restroom. I see some people have already left for their 5-minute break. So let's just continue it for the
Yeah.
5 minutes. Come back.
Okay, so it is like 11:44 now, and that's what I said. Like we were supposed to end by noon. This just takes like 15 minutes. So like if you want to keep going, we can, or if you want to do like the 5 minutes and then come to this, we'll try to have you out of here by like 12:15.
Let's do it. 1, 2, 3, break.
Okay. All right, so we'll start at 11:50. Okay. I don't know. It's good.
I don't even need it. You see, I just had that one bite and I'm like,
Just looking and that's we know. Oh, it feels like a year.
Mm.
Whatever.
All right.
Well,
Huh.
agree.
Started up again because, like I said, I want to be mindful of the time. So, with this next activity, we are going to go upstream together. I was going to have folks get into groups of 3 or 4, but I don't know how are folks feeling about moving and getting into groups because we can do it that way, or I could just show you the worksheet on the screen and then we can have a discussion about. All right, I'll go with that approach then. So let me just click out of this. And I'm going to go over to this document. So it's kind of small. And I did have some printouts of it. So, yeah, if you don't mind, and I'm going to pass this out because that's what's up on the screen. But Angela's going to make some more so everybody can have their own copy. Okay. Mm.
Thank you.
Mhm. Oh. Mhm. Yeah. And yeah, we'll get some more. So basically, the instruction is for us to think about 2 to 3 or however many you want. Let's just say one midstream activity that you can think of that's at the community individual level, and one upstream activity that you can think of that's going to be kind of more policy level, societal level, right? Based on a social or determinant of health that you may be thinking about in the programs that you are working in or your organization, right? So we'll spend some time thinking about that, writing it down, and then come back and just discuss what it is and what you think it takes to actually get that activity going, right? To get that midstream or upstream activity implemented or realized in your community, okay? And we'll spend 15 minutes doing that. Um, Angela got us some more. Oh, it didn't come out right? Oh no. Okay. She's gonna print us some more. And let me know if it would be helpful to put, you know, any of the other slides back up as you think about it. So, okay. Let me- All right, so I could put up this one, or there's this one and this one. These are the specific examples from our Catalyst for Infant Health Equity program. And this is more just, this shows like examples of downstream, midstream, and upstream interventions. Is this one preferable to leave up? Okay. All right. Okay. There we go.
Thank you.
Mhm. Yeah. Mhm.
Thank you.
Mhm. Everybody.
Thank you.
Mhm. You don't have to do it. You don't have to. I wish I hadn't lost that thing. I mean, it was so tiny though. In my pocket. Okay. I hope so. Okay. Maybe I'll put it in my wallet. Oh, uh, you know, no, because I uploaded it. You can find them. Oh, we're just gonna have open discussion. I don't want no problem. You know, yeah. I thought I couldn't even figure out the right receipt. Yeah. Oh, God. Yeah. What the fuck? Um, so they only have contracts through the end of the year, you know that. TA Center. Calandra and Pia. Yeah. Mm-mm. Girl, it would have been like $300 to park at the airport. And it's like Center for Health Equity in Louisiana. No. But yeah. Hmm. Um, about 2 more minutes, okay? No, she's gonna help you start him, yeah. It's so weird. I just put that down. You know, it's time to go. You start losing stuff. 100%. You know? That's all you know. Yeah. And then everything's funny. Everything's funny. Oh, the lady from Downton Abbey died. And Harry Potter. Yeah. So are folks ready to reconvene? Yeah? Okay. Let's put this back in presentation mode. Okay. Alright, so thank you all for participating in that activity. It was really just, opportunity for you to kind of apply what you have learned today and think about your own work and some things you'd like to potentially implement, that might be at the midstream or upstream level with respect to a social determinant of health that your organization or your work focuses on. And so I have some discussion questions, but before we get into that, was this difficult or how did y'all feel about this activity? Midstream was easier than upstream. Mhm. Midstream, okay. Same. Okay. Would anybody like to share what their upstream activity or wish would be? Okay.
So, um, so I thought of maybe having housing, affordable housing, just for homeless prenatal and postpartum women
Mhm.
to until their baby turns like 3 or 4 years of age.
Mhm.
And in that housing system would be equipped uh, with like OBGYN, a pediatrician that comes in on a rotational basis, and any kind of social services that would help the mother also work with job of opportunities in those years of the perinatal health until the baby turns 4 years of age, and then transition them to another affordable housing.
Mhm.
So that way they don't have to go to different locations, and because they're already short on cash and um, other resources, they have everything in one place.
Mhm.
So maybe that is just for targeting homeless women who are and families who are pregnant. That was one for upstream, and another one that I thought was maybe having like cash assistance from the employer
Mhm.
to the women who are pregnant. So maybe that could help give them additional assistance when it comes to income
Mhm.
and economic stability and midstream as well.
Yeah.
Okay.
Yeah.
So midstream, I was thinking of maybe um having the community spaces or maybe like a clinic or any kind of community resource to be mindful of women who are breastfeeding. So maybe have like rooms dedicated to lactation just for that.
Mhm.
Also, I know that Israel has an option of rideshare services that gives free rideshare options to women who are pregnant. So maybe having that with a majority of those clinics and other medical facilities. Another one is doulas because I know at NCHC as well, the doulas are doing a great job in educating women. So maybe bringing them as well and putting them in the forefront of um, uh, the activities and like helping pregnant women understand their own body and their health as well as infant health.
Mhm.
And last is, I'm not sure if this fits in midstream or upstream. I think it's both
Mhm.
maternal and paternal leave.
Oh yeah, that's definitely going upstream. Yeah. Yeah. That's great. Thank you so much. Like you hit everything, right? So I have a question for you. For your first upstream activity, like what partners are needed or do you think are needed to implement that? Especially when you're talking about housing, co-located services, you're giving them 4 years, to get it together basically before they have to transition out. So where do you like who are the partners you need to bring to the table?
So I feel it be definitely first of all real estate agents and people who are responsible for um space, but they can dedicate a particular space to house building that particular housing. Another would be, of course, government officials responsible for implementing that policy. Also making sure you're talking to the community and like knowing your population and how many people are homeless or which women really need that kind of resource, knowing that quantity that number as well. Then I would say also talking to your local healthcare organizations and even sometimes faith-based organizations because they may have access or they may know certain individuals who need this resource. So maybe I feel just talking to the community in general and different people from various organizations would help.
Yep. I love it. Thank you. It was like she covered so much, got like her partners in place, and I mean, okay, this is where drive up this work. We're looking forward to seeing that happen. Would anyone else like to share?
So as I mentioned, I work for an adoption agency, and what we like to do is we have like these in services with social workers, nurses, anyone who really is in close contact with a pregnant woman or someone who just found out that they are pregnant, or when expected to be pregnant. So we really like to educate them on the services and the options that these pregnant women have if they're not sure about parenting, just so that the nurses and the social workers know what the resources are available. They can bring it to the nurses. Because a lot of times they don't know what information, they don't have the proper information to provide birth moms, they don't know what other services are out there. Sometimes they resort to DCBT right away. That's not necessarily, built into the child care system. It becomes, there's a lot of legalities involved, whereas they can just offer comfort to the mom to just explore the options. With the informing, people in the community who are going to see these studies women, they're able to bring in information from anywhere.
That is actually a very ideal kind of midstream activity because it's like raising a level of awareness at the individual and community level. Right. Thank you for sharing that. Um, so let's see if anyone else wants to join in. If not, like I do have these discussion questions. Do you feel like you have a really good understanding of just what we mean by a midstream or upstream activity that could potentially improve infant health outcomes? Yes. Anybody on the fence where they're like, I don't know what you were just talking about for 2 hours? Okay. All right. So You said it was difficult to think of upstream activities. Why?
I'm, I guess because of what I do, I'm more community. So I'm
Mm,
and deal with is the locals and the community. I don't really, other than my day-to-day activity with the state in the aspect of they regulate everything that touches one of our members. I don't really think that way. I think more
mm-hmm.
local, more person's right in front of me right now. What can I do to make it better for that this person?
Oh, gotcha. Okay, right. So if you were to go upstream with your work, right? So I hear what you're saying, right? Like, so let's say, like, I want to help that person that's right here, right now, get them connected to the resource they need. And then you realize, like, okay, I'm still not preventing this problem, right? Or if there isn't a problem, you may be thinking, like, gosh, there's so many needs, right? With the kind of work that you do, right? Especially like working in an with an healthcare insurance company. Like, do you ever think about like, wow, if only like our leadership would do this one thing, and then it wouldn't be like a long waiting list, or whatever might come up in your day to day. Yes. Uh-huh.
That
Hmm. Gotcha.
Um, for the healthcare access, it's a quality.
Mhm.
So maybe those who study any type of medical or medicine, that they create a policy that's like nationwide and requires all medical professions to take a diversity and medicine class.
Yes.
With a biannual training, like every 2 years, like follow up. They don't follow through, then some type of disciplinary action. Or meaning they can you get suspended from work or some pay as you hit the pockets. People get like
I love that idea, right? And actually, so where I'm from in Maryland, in order for me to maintain my license to continue to do therapy, I have to, every time I renew my license, show them my certification that I did, a cultural competency training, and now I also have to do one that is specific to um, like special populations, right? LGBTQ plus population, and then also the military population, right? So there are some states that have required this for certain types of professions, right? And I love this idea because then like if you're doing a healthcare profession where you have to, relicense yourself or recertify, you'll be thinking about it every time that license needs renewal, right? So thank you for that. That's great. And it would be great if it was actually like embedded into the provider's curriculum when they're in school, right? Yeah.
HRSA. At HRSA, we have the Bureau of Health Workforce,
Hmm.
and we do provide funding to freestanding children hospitals, and we do require them to have cultural competency training. It's called the Children's Graduate Medical Education Program.
Hmm.
And so public health professionals like ourselves are the ones that are identifying the types of education they need to receive in addition to their clinical education. But again, those are only at freestanding teaching hospitals, and those are specifically for pediatric residents. So it's not across the board, but it's coming. It's trying. And that's
Slowly but surely.
been around for,
Yeah.
again, only those who are residents at freestanding children's hospitals.
Hmm. Yeah.
Can I say something?
Yeah.
In New Jersey, I think there is a requirement for licensure for medical professionals to take at least 6 CEs or credits, educational credits for cultural sensitivity training. So when you become a physician, a licensed physician, is that you need to take those CEs.
Hmm.
Right, and there's also right now, Governor Murphy signed into law in 2021 for hospitals to take implicit and explicit bias training.
Hmm.
These are all courses we had to take at Horizon, like they're mandatory. You don't take them.
Hmm.
It's like all of them, the
biases, cultural competency, specialty, like
Yeah. Yeah. Mhm.
Right. Right. And this is included.
Could become a mandatory law.
Is now mandatory. You need
If
to
it's not
say.
in every state.
Oh, okay.
Yeah.
Right. This is
Also
just New
passed.
Jersey for now, but I know in other states it's also required.
Mm. Beautiful. I like this discussion, right? Because we're also like sharing information of like where it's happening and where it's not, right? I've heard some pushback on like requiring, like health providers to do it because, um, I don't even want to say the word, but they don't feel like providers should have to do that additional layer of training because, well, they're already trained to treat everyone, but they don't, and there's been pushback on it, but like, you know, depending on the region or the type of state you live in politically, so.
And it's also look at the patient level. You look at their experience with the provider, for example, or the clinical team members, where sometimes there's breakdown in communication. It's so simple, and it was more about willing either the clinician not really being in tune with the cultural beliefs of that person or the background that kind of led them to make certain health decisions. And that can create some miscommunication. And then when it comes time for patient feedback, you look at the patient feedback like, oh, the patient said, poor quality of care, and that they felt disrespected, they felt unheard during the office visit. But when you look at some of those patient feedback and you actually hear everyone's side of the story, then you start making those connections and you bring it back to the cognition. This is, what transpiring, and we hope that there is that culture of humility in the process. When many times, some providers will, why do you see it that way? I didn't realize that's how it was coming across to the patient. So I think, yeah, that's very important.
I would add to that to say that, it's definitely necessary. I have heard pushback and conversations around, well, we've already went through these years of training and professional across the board. So why would we need to do that? But just like in any role, not just picking on the medical industry, in any role, individuals sometimes become numb or like kind of performing like a robot. This is what I do every day. They do the same thing. And you need those cultural sensitivity reminders and doing those trainings and having that requirement of them having to do it again. Like in Goodwill, across the board does that. If you're the janitor, cleaning the toilet, or whatever, everyone have to do trainings over and over. We have to implement it continuously into our work day or our schedules, and it's necessary because we know that a lot of people of color experience gaslighting. That speaks to the cultural sensitivity of seeing an individual as an individual, regardless to what you think their background is, their culture is, their experience is, whether you think they're feeling pain or how much pain they can take or not take. It helps to start dissolving those biases.
Yes.
So,
Thank you. I appreciate that. So I want us to, I'm gonna wrap this up because I know it's been a long morning. We're already into the afternoon. But before I do, I just wanted to express my gratitude to you all for, your participation in this and, being willing to learn about, what do we mean by the structural and social determinants of health, and, why are we doing this work to go upstream to address infant mortality, particularly for the populations that are experiencing the highest rates. And so I know it's like a Friday and, it's a dreary day, but I hope that you have found this to be part of your lovely day, learning about this information, and we'll take it back to your respective agencies and organizations and the work that you do, and share it too. Like I said, Angela can share these slides with you. And just be thinking about this as you progress in your own work. Like, what can we do to make things more equitable? Oh, excellent. Thank you. Yeah, thank you. Hello. Mhm. Yeah. Mhm.
Now you can make all the assignments.
Absolutely.
Now
Oh, I didn't sign.
the side.
Mhm. Oh, you're welcome.
Nice to just see things from a different
Perspective, right?
and we're working together here and at DEI, we'll get it ready.
Mhm.
So it was really nice that piece.